Hello, Assalamu alaikum, everybody. I hope you are good after Eid holidays, and I'm after Eid. Okay, today we are going to discuss great topic, but interestingly, scleroderma. Basically, one of the diseases which are chronic diseases leading to skin manifestations and systemic manifestations like involvement of the lungs, kidneys, heart, and different organs. And it is a scleroderma. Basically, systemic sclerosis is a chronic disease leading to dermal manifestation. There is a thickening of the skin leading to fibrosis, and later on there is a multi-systemic involvement. Basically, it is a two types scleroderma. One is the limited and one is the diffuse disease. Limited disease is a milder disease which leads to thickening of the skin, usually involving the face, neck, and distal extremities. It does not cause any visceral involvement like heart, kidneys, and the lungs. Whereas diffuse disease, scleroderma, is a bad disease that is a worse prognosis that cause systemic manifestations as well as diffuse skin involvement, including the face, trunk. Trunk is the most, in limited disease, trunk is not involved. While in diffuse systemic sclerosis, diffuse scleroderma, it is involvement of the trunk, the skin become edematous, and there is a depigmentation and hyperpigmentation with systemic involvement, especially the kidneys can lead to renal crisis, hypertension, your heart can be involved leading to pericarditis, heart blocks, myocardial fibrosis leading to heart failure, and there is a involvement of the pulmonary vasculature leading to pulmonary hypertension and right heart failure. So limited disease is a better disease limited to skin, real involvement of the internal organs, but sometimes it can present with crest syndrome. Crest syndrome we'll discuss later on. So limited disease with the crest syndrome, better prognosis, and no visceral involvement. While diffuse disease, there is a more severe involvement of the internal organs like heart, kidney, lungs, and the gastrointestinal tract, leading to gastric motility disorders and malabsorption syndrome. So we'll discuss what is systemic sclerosis. So it is a multisystemic disorder characterized by functional and structural abnormalities of the blood vessels. So what happens is there is a intimal thickening and growth leading to fibrosis of the microvasculature. And skin, there is a thickening and fibrosis of skin, and there is a internal organ involvement like heart, kidney, lungs, and gastrointestinal tract. And there is immune. This is a sum of the immune mediated disease like SLE, muscular tissue disorder, and inflammatory myositis. So it is an inflammatory disease, maybe because of some autoimmune activation. And autoimmunity is like the SLE. You can will see how the ANA or the antibodies are positive. So systemic sclerosis may be is a diffuse uh, thickening of and fibrosis of the skin and involvement of the internal organs. Usually, it is more common in females than males. Males have a worse prognosis as compared to females. Usually, the female male ratio is 3 into 1, and the age of onset is between 30 and 50 years of age. So these are the patients who usually present with Raynaud's phenomenon. Usually, most common early manifestation is a Raynaud's phenomenon, especially in winter season. Females are more commonly involved in genetic background. Blacks are more commonly involved in western part of the world, and here there is a mixed distribution. So systemic sclerosis can be divided into two major types. Diffuse cutaneous systemic sclerosis, which is diffuse disease leading to skin manifestation and involvement of the internal organs. Like I just told you, heart, kidney, lungs, and your gastrointestinal tract. While limited disease is a limited to only skin involvement, usually involving the face, neck, and distal parts of the body. Trunk is usually not involved, and there is no visceral involvement in limited systemic sclerosis. Overlap syndrome, like you can have mixed connective tissue disorder syndrome, but sometimes systemic sclerosis is a mostly diffuse disease which is found in 20% of patients. In 80%, it is a limited disease without any visceral involvement. So sometimes there is a small variation of group which are very minimum disease like localized scleroderma, which is called morphia. I mean, there is a localized thickening of the skin which become non-edematous and then leads to fibrosis and hypoesthesia. So this is a very limited disease to some patch of skin with a very good prognosis. No diffuse disease, no visceral involvement. It is a disease with the limited skin involvement called morphia. Linear scleroderma, another variety of minor disease. So we'll discuss basically the two main types, which is the diffuse cutaneous systemic thickening and fibrosis that is called systemic sclerosis. Usually there is a proximal skin thickening. So proximal thickening and distal proximal extremities are often the trunk and the face. As I told you, in diffuse disease, there is a diffuse thickening of the skin leading to fibrosis and usually involving the face, the neck, trunk is mostly involved, and it lead to involvement of the digits and the lower limbs. So there is a rapid progression to skin thickening and fibrosis and rapid onset of Raynaud's phenomena. So this is that usually patient present with Raynaud's phenomena. They say they have very severe pain in their hands while in winter season they become white, blue, and they are very painful. And these are the patients who have a high risk of getting visceral involvement, like lungs. They can have small visceral capillary leading to pulmonary hypertension, and they can lead to right heart failure. While cardiac involvement may have pericarditis, they may have heart blocks, they may have endomyocardial fibrosis. There is a diffuse thickening of the myocardium leading to restrictive cardiomyopathy and right heart failure. And these are the patients who have a poor prognosis. So this is found in 20% of patients who have a scleroderma. So scleroderma with diffuse systemic sclerosis, diffuse involvement of the skin, especially the trunk, with pigmentation and a depigmentation, hyperpigmentation. Some patches are hyperpigmented, some are depigmented, and it is a progressive disease presenting with Raynaud's phenomena, and sometimes even patient with present with hypertensive crisis that is called renal crisis. Patient present with the 220 by 120 blood pressure and they are in hypertensive crisis. And these are the patients who have a low risk because they can have the GI tract involvement, they can have because of motility disorder, they can have malabsorption syndrome, they can have diverticular diseases, and they can have bacterial overgrowth leading to malabsorption. So motility disorder in gastrointestinal tract, cardiac involvement, pulmonary involvement leading to pulmonary hypertension, and renal crisis may present with uncontrolled hypertension. While limited disease is a symmetrical restrictive fibrosis. So this is not involving the internal organs, but it is only involving the distal extremities and the face and the neck. So there will be thickening of the skin and may lead to mild restrictive fibrosis only the extremities, the face, and the neck. So it can be a distinctive feature of in as compared to systemic sclerosis diffuse disease. There is a really no involvement or very rare no involvement of the internal organs. It can present with Crest syndrome. That is, Crest syndrome means there is a calcinosis, there is Raynaud's phenomena, esophageal motility disorder, sclerodactyly, and telangiectasia. So limited disease usually presents with mild skin manifestation without internal organ involvement, and that is a variant of limited disease is a Crest syndrome. So these are the patients who are usually 80% of patients with scleroderma, which is a limited disease, and they have a better prognosis as compared to patients with diffuse disease who have diffuse skin thickening, fibrosis, depigmentation, hyperpigmentation, rapid progression of the disease, and involvement of the internal organs like GI tract, your kidney, your heart, and pulmonary circulation leading to pulmonary hypertension, and they have a bad prognosis. While limited disease, I told you, is a milder disease in found in 80% of patients with scleroderma, and they have a good prognosis. They usually present with Raynaud's phenomena and CREST syndrome, that is calcinosis cutis, Raynaud's phenomena, esophageal motility disorder, and sclerodactyly and telangiectasia. And overlap syndrome is another disease which can patient can have mixed autoimmune disease like a combination of rheumatoid arthritis, SLE, or polymyositis. This is called overlap syndrome. Patient presenting with Raynaud's phenomena, but they have mixed variety of connective disorders like they can have polyarthritis, like rheumatoid picture, they can have lupus-like pictures, there is skin rash, and anti-DNA, anti-dsDNA may be positive, and they may have polymyositis and proximal myopathy with polymyositis. That is called overlap syndrome. So we have main three varieties. That is diffuse disease, that is scleroderma, that is called systemic sclerosis, that is the bad prognosis and visceral involvement. Limited disease with skin manifestation and no visceral involvement, and usually present with CREST syndrome. And you have overlap syndrome. Okay, so what are the factors which can lead to a patient have a scleroderma? So there are different factors which are involved. Like if you look at the professional risks, like silica dust can in patient with interstitial lung disease, once you are exposed to silica dust, that can lead to diffuse pulmonary fibrosis, but that can be one of the factor for scleroderma. Organic solvents, biogenic amines, urea, these are all the agents which can lead to some autoimmune disturbance, precipitating an inflammatory disease leading to multisystemic involvement. Polyvinyl chloride, rapeseed oil, and bleomycin, epiprophan, and silicone implant. These are the basically some irritating agents or leading to some inflammation and immune regulation, leading to some autoimmune disorder, leading to diffuse involvement of the inflammatory and chronic disorder leading to scleroderma. Genetic polymorphism, as I told you, this is more common in females than males. Male have a bad prognosis, but usually blacks are more common involved than white. And it is cell-mediated immunity, CD4, CD8 cytokines are the inflammatory process, which can lead to high inflammation in the body and leading to cell-mediated immunity. And there is a humoral immunity, that is hypergammaglobulinemia, autoantibody production like SCL70 antibody and ANA antibodies. They are the humoral immunity which can lead to precipitation of chronic inflammation leading to scleroderma. Pathogens, if you look at the patient who is exposed to some exogenous events that leading to immune autoregulation, immune system activation, leading to fibroblast activation, and there is a endothelial cell activation, leading to you have a thickening of the skin and later on lead to fibrosis. So first of all, patient will complain of thickening of the skin, tight skin, which has lost its wrinkles. It will be shining, edematous, non-pitting edema. So it will be non-pitting edema of the digits, your hands, face, neck. Maybe if there is a diffuse disease, it may be involve the trunk and distal extremities. So non-pitting, swelling, thickening of the skin leading to fibrosis, and that can lead to loss of your skin pulps and like Rest syndrome with the Raynaud's phenomenon, digital ischemia. So this is the pathological process. Immune system activation leading to fibroblast activation and endothelial cell activation leading to end stage obliterative vasculopathy and fibrosis. Obliterative vasculopathy, there is an intimal growth of the small arteries, especially the renal small vessels are uh, intimal growth leading to renal hypoperfusion and renal and RAS activation. So these are the patients who have better response to AS and ARBs, because these are the patients who have a renal vasculopathy leading to renal hypertension, and ACE inhibitors as they are drug of choice, and skin fibrosis leading to depigmentation, hyperpigmentation, lung involvement leading to interstitial lung disease, pulmonary fibrosis, pulmonary hypertension, heart failure, and heart with the cardiac defects, endomyocardial fibrosis, myocardial fibrosis with restrictive cardiomyopathy and heart failure, and sometimes they can present with pericarditis and chest pain. So vasculopathy, told you, is a very important part of your pathogenesis, involving the small and arteries and the capillaries. So endothelial cell injury, adhesions and activation of the platelets, PG, thromboxane, A2 release, and vasoconstriction and growth of endothelial cell fibroblast, leading to narrowing, obliteration, and decreased permeability. So this is the whole cascade of events which takes place in vasculopathy, leading to intimal growth, and there is a narrowing and obliteration of the vessels, especially the renal and pulmonary vessels. They have a patient can be become in hypertensive crisis. Fibrosis, uh, the mechanism is aberrant regulation of the fibroblast cell growth and increased production of cell matrix, leading to collagen and fibronectin and glycans. So what happens, there is a thickening of the skin leading to fibrosis and involvement of the fibrosis of the internal organ, especially leading to vasculopathy. So this is the whole pathophysiology. Means you have some inflammatory process, but it is autoimmune regulated, or some external factors leading to your release of prostaglandin factor, thromboxane, and the activation of the endothelial fibroblast, and leading to obliteration and the thickening of the skin and internal organs damage. What are the manifestations? So if you think about the mild disease, which is a limited disease, usually patient present with a CREST syndrome, that is the Raynaud's phenomenon, is the most common manifestation, whether it is a diffuse disease or it is a limited disease. So patient will complain of cold hands and feet with the reversible skin color. First it becomes white because of vasoconstriction, then blue, and they leading to there is a reactive vasodilatation. So white, blue, and red is a color change. First there is ischemia, then there is a reduced blood flow leading to cyanosis, blue skin, and then there is a reactive hyperemia leading. Then pain is having severe pain in the hands, and this is usually precipitated by cold temperature and emotional stress. So initial complaint in two-thirds of 3/4 of patient is a Raynaud's phenomenon. 90% of patients usually have a skin changes if they are in the early phase of Raynaud's phenomenon. So radar phenomena, otherwise prevalence is 4 to 15% without Crest syndrome, but usually if patient is having limited disease, it will have Crest syndrome with Raynaud's phenomena, or will have systemic disease with Raynaud's phenomena. So digital ischemia injury can lead to digital pulp atrophy, digital loss, even they can become necrotic, and gangrene can take place because of the digital ischemia. So these are the patients who can have their fingertip loss because of the recurrent ischemia and loss of pulp. This is the Raynaud's phenomena. You can see the digits become white, then they will become blue and red because of hyperemia, vascular ischemia. This is the blue stage. You can see the white, then the digits become blue, and there is a atrophy of the, if you look at the atrophy of the pulp, and you can see there is a the digital blue and cyanosis. So this is a white, blue, and red discoloration in a Raynaud's phenomenon. So Raynaud's phenomenon, what happens if you do a renal the angiogram of the hands, you will see there is a narrow enclosure of the digital arteries. You can see there is a good small vessels here, but there is a loss of flow of the contrast in the digital part of the hands. So this is the one of the vasculopathy leading to fibrosis, intimal overgrowth leading to ischemia of the hand. You can see the dye is not going to the distal part of the hands, and digits are almost they are lost, leading to recurrent ischemia and leading to pulp atrophy. So proximal vessels, arcades, and metacarpal vessels are widely patent, while the distal small vessels are almost there is a no flow. This is the you can see in arteriogram. Other patients who have skin manifestation, they can have telangiectasia. You can see the skin, there is a small dilatation of the arteries causing local disruption and angiogenesis. So they blanch on pressure. So these are the telangiectasia, which can be seen in on skin, their mucous membrane like tongue and the lips. So this is the telangiectasia that can be seen in part of Crest syndrome. So clinical manifestation, clinical feature, usually these are the patients who present with skin involvement. Stage 1, they may have edematous phase, indudative phase, and atrophic phase. So this is the skin inflammation leading to thickening and leading to fibrosis. So there is a firm, thickened skin which is bound to the soft tissues and decreased range of motion with loss of expression. The patient face become wax type with no expression, and it is a thick, tight skin which is because of edema and thickening of the skin. So patient is will complain of difficulty opening the mouth fully, and they may lead to contractures and small peaked nose and furrows around the tongue, around the lips, that can be leading to later on fibrosis and so this is the edematous. You can see the hands, uh, they are tight skin which is thickened and edematous. So thickening, shining, edematous skin, and there is a non-pitting swelling. This is the edematous phase of the hands. And then you can see the skin induration with the digital ischemia leading to pulp loss, pulp atrophy. There is this area of gangrene, and there is a vasculopathy at the same time. And the patient will complain of recurrent ischemia, Raynaud phenomena. Even they have a digital loss, and you can see the atherosclerosis. They have fibrosis and leading to deformities. And this is the picture of recurrent ischemia, Raynaud phenomena leading to pulp loss, and sometimes there is a digit loss. This is atherosclerosis patient. You will see the X-ray will have a calcification, and this is the facial typical face of the patient with scleroderma. You can see the tight skin of the face and difficult to opening the mouth. There are wrinkles around the lips and peaked nose. And patient initial phase there will be edematous skin, and then you become atrophic, and there is a difficulty opening the mouth, and the patient have even dysphagia because of the motility disorder. The intestine will discuss it later on. So this is the typical face of a lady with scleroderma. So skin involvement, as I told you, is there is sometimes lead to ulceration, loss of soft tissue, fingertips, and pigmentation, calcification, and there is a capillary damage. So this is an inflammatory and chronic disorder that can lead to ulceration, loss of fingertip, and because of recurrent ischemia, hyperpigmentation, depigmentation, or there may be calcific deposits and capillary damage because of the intimal overgrowth and fibrosis. Musculoskeletal system, they may have polyarthritis with flexion contractures, muscle weakness, and atrophy like proximal myopathy with the maybe part of primary or even part of overlap syndrome with the scleroderma. This is a terminal digital resorption. You can see the terminal part of the finger tips are lost, almost they are damaged, and there is a loss of fingertips, and there is a telangiectasia of the skin, thick fibrosis of the hands, and there is a tip loss, digital loss. This is, you can see the acrolysis, that is your the bone become resorbed, and there is a tip loss leading to acrolysis, and there is some area of calcification. This is a digital pitting scar. You can see the pitting of the in initial phase. There will be a small pitting area of the skin, then lead to localized fibrosis, and thickening leading to localized fibrosis of the tip of the finger. And these are the patients who have a CREST syndrome, that means calcinosis cutis. Raynaud's syndrome already discussed. They have estrogen motility disorder, and we'll discuss later on the GI manifestation. So this is the typical calcinosis cutis of patient with CREST syndrome, and you can see the calcification of the patient with acrolysis. So this is the typical feature of patient with advanced CREST syndrome with calcinosis cutis and acrolysis. You can see that there is huge calcification, and fingertip are lost almost. The terminal filling arcs are lost. So other manifestation like GI involvement in diffuse disease, diffuse scleroderma, that is systemic sclerosis, can lead to esophageal involvement. Patient may present with dysphagia, hypomotility disorder. Sometimes there is element of reflux esophagitis, and can have a stricture leading to atrophic esophagus leading to stricture formation. The patient may present with initially with GERD symptoms, or may have dysphagia later on leading to stricture formation in the lower part of the esophagus. Stomach, there is a delayed emptying, and because of the muscles of the stomach are fibrous, and there is a delayed emptying. And intestine, very important part, is they can lead to pseudo obstruction, paralytic ileus, malabsorption because of bacterial overgrowth, and there may be wide mouth diverticular disease can be found. So because of the low transit time of the gut, there will be bacterial overgrowth. Patient may have element of malabsorption with cachexia, weight loss, and there is a GI involvement leading to pseudo obstruction. Sometimes it can cause even intestinal rupture. There is a pseudo obstruction. Patient may present with alternating constipation and diarrhea, and because of the motility disorder. Large intestine can lead to chronic constipation, fecal infection, and leading to wide mouth diverticular disease of the colon. These are the motility disorder which can be seen on barium swallow of the patient. You can see the patient will have a stricture over there and dilatation, and there is a stricture. This is the diverticle of the small esophagus. And this is another diverticular disease. You can see the wide mouth diverticula which are seen in the transverse colon and the distal colon. So these are the typical manifestation of barium edema, with multiple wide mouth diverticle of the colon and broad waist. And usually these are the patients who may present with acute abdomen with diverticulitis. If they have a acute abdomen, they can present with diverticulitis. So this is another very good variant examination of the large gut, showing the wide mouth. This is the wide mouth diverticula, and that can lead to even hemorrhage, infection, and perforation. That is, a patient may present with massive bleeding within the, or may present diverticulitis leading to acute abdomen. Okay, pulmonary manifestation, as I told you, is another element of diffuse disease that is very bad. Patient initially will have difficulty in on exertion. He will get dyspnea on exertion and may present with even later on with a severe hypoxemia. The truth of the patient who have a diffuse disease, they lead to mortality. They say the high morbidity and mortality because of the interstitial lung disease and pulmonary fibrosis. So there is interstitial fibrosis, intimal thickening of the pulmonary artery leading to pulmonary hypertension, and patient end of the day leading to right heart failure. So pulmonary hypertension because of the fibrosis and intimal thickening of the pulmonary arteries with pulmonary hypertension and right heart failure. And patient may complain of suprarenal infection with initial phase dry cough and breathlessness, but later on may present with respiratory failure and pulmonary hypertension with right heart failure. This is a typical chest X-ray of the patient with pulmonary. You can see the basement lungs are is a honeycombing of the bases with interstitial fibrosis, and patient have a typical X-ray. You can go for HRCT to see the interstitial fibrosis and the severity of the lung fibrosis. Cardiac manifestation, I told you the patient can have pericarditis, heart blocks, myocardial fibrosis, arrhythmias, and can have congestive restrictive heart failure. Restrictive heart failure because the myocardium is fibrosed, it is unable to dilate. So it is a restrictive cardiomyopathy leading to pericarditis. So patient may present with acute chest pain with pericarditis. You can go for echocardiogram and you can see the ECG changes. Patient may have tachycardia and STT changes. Heart failure, usually these are the patients who have a right heart failure because of the superior pulmonary hypertension, and or they can have congestive heart failure because of myocardial fibrosis leading to both left and right heart failure. Signs of right heart failure like raised GVP, hepatomegaly, peripheral edema, and the patient will have a pulmonary crackles because of superadded right heart pulmonary fibrosis. Arrhythmia, any sort of arrhythmia, either atrial or ventricular arrhythmia. Usually these are patients who have a heart blocks because of that the conduction system is also there is a area of fibrosis leading to heart blocks and myocardial fibrosis leading to restrictive cardiomyopathy. Renal manifestations are very, very important because these are the patients who have intimal hypertrophy of the small capillaries of the kidneys. Small vessel capillaries leading to activation of renal angiotensin system. So there may be in diffuse scleroderma, patient will have rapid involvement of the kidneys with intimal hyperplasia and interlobular arteries. There is a fibrinoid necrosis of the afferent arteriole leading to glomerulosclerosis. So this is the cascade of events that lead to renal hypertension, and patient may have proteinuria, abdominal sediment, azotemia, may have renal failure. Microangiopathy hemolytic anemia is another manifestation because microangiopathy hemolytic anemia means the small vessels of the body are they have a decreased circulation because of intimal hyperplasia, and red cells are damaged because like DIC, like other hemolytic anemias, and patient can have angiopathic hemolytic anemia or leading to renal failure. So renal crisis is the condition when the patient presents with the uncontrolled hypertension, 220, 120 blood pressure, and they are in hypertensive crisis because of the underlying renal involvement due to scleroderma. This is the renal arteriogram. You can see the normal kidney with a good perfused kidney, but you can see the your peripheral vessels are choked, and there is a reduced flow in the kidney, and there is a area of loss of blood flow with dilatation, and there is a diffuse fibrosis of the and the intimal hyperplasia leading to renal hypertension. This is the, if you look at the renal artery intimal fibrosis, and there you can see the histopathological picture of kidney. Okay, now exocrine gland, like patient may have dry skin, dry eyes, dry can have xerostomia and ophthalmia. Like the patient with Sjogren syndrome, these are the patients who can have decreased function of the exocrine glands. Okay, so you have a 45, 35 female present to you with history of pain in their hand during winter season. She says they become blue, and she has a clinical manifestation of Raynaud's phenomenon. If you look at the skin, they may have diffuse thickening and fibrosis of the skin, and you check the blood pressure, you have a high blood pressure because of the renal involvement. If you auscultate the chest, they may have pulmonary fibrosis, or may have evidence of heart failure. So these are the patients who can present usually Raynaud's phenomena with the GI disorder, with the, a motility disorder, or may present with hypertension or heart failure in advanced disease, or even renal failure in advanced disease. So you suspect the disease, and what are the investigation you will ask in these patients who are suspected to have scleroderma. So you will, the hallmark of the you is ANA. ANA is almost positive in almost all patients with diffuse scleroderma. Rheumatoid factor, sometimes 30 to 40% of patients is positive. Anti-SCL70, this is the antibody which is have a bad prognosis. Anti-centromere antibody is a bad prognostic sign. These are the patients who have anti-SCL70. They are the patients who have a diffuse disease, and usually they have a diffuse disease, and they have a bad prognosis if patient is having NTCL70. So NTCL positivity is a indicator of diffuse disease usually in 20 to 40% of patients, but ANA is almost always present in patients with scleroderma. So NTCL70 is a element of is a picture of patient with a diffuse disease in 20 to 40% of patients, and they will have in a limited disease, they will have only in 10 to 15% of patients. Anti-centroviral antibodies, it is found in 50 to 90% antibodies, but in diffuse disease, it is only 5%. So ANA would be present in almost all patients. If they have an anti-SCL70, that means it is usually a diffuse disease and bad prognosis. Anti-centroviral antibodies usually a feature of limited disease, which is having a better prognosis. Otherwise, you will go for CBC, CRP level, ESR may be normal, but that patient who can have anemia, and they may have microangiopathic hemolytic anemia, raised ESR maybe there, but they can have renal impairment, will go for ACE level. So these are the patients who are suspected, and you go for ANA and anti-SCL70 and anti-centromere antibody to see whether it is a diffuse disease or it is a limited disease. So diagnostic major criteria, you have proximal scleroderma. Minor criteria is sclerodactyly, digital pitting, scar, or loss of substance from the finger pads, the finger pulp atrophy, and bibasilar pulmonary fibrosis. So one major or two minor or one major criteria, this is the diagnostic criteria for scleroderma. Okay, so what is the treatment option we are left? These are the patients who have a chronic disease, and they are usually given symptomatic treatment, because if they have reflux disease, they can given education to avoid heavy meals at dinner, because they are going to have a reflux, they cannot sleep, or they can have risk of aspiration pneumonia. PPIs are given to reduce the excess secretion, and patient will discuss the renal and pulmonary involvement. So wide spectrum clinical manifestation and severity depends upon the improvement and how disease modifying intervention. So what are the it is an autoimmune disorder, and what are the drugs which can disease modify autoimmune disease like penicillamine, methotrexate, immunosuppressant like cyclosporine, and internuclear factor, and recombinant relaxant. So steroids have been used, but they are not that effective in a patient with scleroderma. Only what you do is that you give non-specific treatment, symptomatic organ-specific treatment, especially if patient have element of hypertension because of renal involvement. They are given ACE inhibitor, because that is the only drug of choice, because when aldosterone is activated, you go for ACE or ARBs. And for GI tract, you can go for PPI and small frequent meals. Like Raynaud's phenomena is a very bad, especially in patients in winter season. They have pain in their hand, and sometimes they lead to recurrent ischemia, lead to digital loss and atrophy of the pulp. So these are the patients who are given education regarding the disease, and they are given guidelines to avoid exposure to cold, especially they can keep their hand warm, and with the if they are smoker, they quit smoking, and vasodilator therapy. That's the important part, especially the calcium channel blocker. Then nifedipine, trazodone, ACE inhibitor, or sildenafil. So these are the drugs which are given as a vasodilator to increase the perfusion of the digital digits and to avoid the Raynaud's phenomenon. Whereas the IV prostaglandins and PG, these are the may lead to even amputation if these are the patients who are not treated at the early phase of Raynaud's phenomena, because recurrent digital ischemia can lead to pulp loss and digital gangrene, and that lead to amputation. So calcium channel blocker and general education of the patient to avoid exposure to cold and even warm heated gloves can be used to avoid the vasoconstriction, and they are given vasodilator therapy like calcium channel blockers. Gastrointestinal tract, I told you these are the patients who have a reduced motility of the stomach, of the esophagus, stomach, small intestine, and large intestine. So for motility disorder, uh, elevate the head of the bed, because these are the patients who have a high risk of reflux esophagitis and they have a GERD, symptoms of GERD. If you elevate their head side, that will prevent their reflux from the stomach to the esophagus, and their burning and reflux esophagitis will be less as compared to, and especially the night meals. They are usually avoided in these patients, because they can take early meals and early small meals and avoidance of the night meals. Small frequent meals and avoiding lying down 3 to 4 hours after eating. So they should be educated. Don't lie down or sleep within 1 or 2 hours, because that can cause to reflux esophagitis and they can have even aspiration pneumonias. So caffeine containing beverages and cigarette smoking should be avoided. H2 blocker PPIs are used to reduce the acidity of the stomach, pH of the stomach, to prevent the reflux and burning. Gastroparesis, motility drugs like metoclopramide and are given. A patient who have decreased intestinal motility, especially the jejunum, small intestine, and they can have malabsorption syndrome due to bacterial overgrowth. These are the patients who are even if they have anorexia, cachexia, weight loss, you see the element of malabsorption. They are given broad spectrum antibiotic like bibramycin, 100 milligram per day for 4 to 6 weeks to treat as a malabsorption syndrome due to bacterial overgrowth. Pulmonary manifestation, I told you, leading to small capillary obstruction, leading to pulmonary fibrosis and pulmonary hypertension. And these are the patients who are even trial of corticosteroids, cyclophosphamide, and azathioprine as a steroid-sparing drugs. While pulmonary hypertension, you can use calcium channel blocker, prostacyclin, and transplant, heart lung transplantation. If patient have end-stage pulmonary disease and they have severe hypoxemia, they go to heart lung transplantation for advanced pulmonary disease. Renal involvement, as I told you, renal crisis. This is a very, very important part of patient with scleroderma. These are the patients who can have high blood pressure at times, leading that's called renal crisis. So early detection with ACE inhibitor. So ACE inhibitor is a very good, especially the captopril. These are the patients who are given 50 milligram uh, 4 to 6 hourly to as a ACE inhibitors, and survival, 1 year survival with captopril is 76%. So 1 year survival without captopril and 1 year survival with captopril. So you can see the how good these drugs are. You can prevent the morbidity and mortality of your patient by early recognition of the crisis, renal hypertension, and putting them on captopril. And these are the drugs which are drug of choice in patients with scleroderma who develop hypertension, and they have a better prognosis as compared to other drugs. So prognosis, if you have a diffuse disease and limited disease, 5 year survival. In diffuse disease is 70% and limited disease is 90%. While 10 year survival in diffuse is 50% and limited disease. So limited disease has a better prognosis. Limited disease a better prognosis as compared to a diffuse disease, because major cause of death is renal involvement. Patient may have renal hypertension, hypertensive crisis, not only renal, but because of uncontrolled hypertension, 220, 120 can have a hemorrhagic stroke. So these are the patients who have a uncontrolled renal hypertension. These are the one of the cause of stroke or even renal failure itself. Cardiac involvement, or you can have pericarditis, especially the patients who have a myocardial fibrosis, they go into congestive heart failure. And pulmonary involvement with the pulmonary hypertension, with the pulmonary interstitial fibrosis, can have respiratory failure, hypoxemia, chronic leading to pulmonary hypertension, and right heart failure. So these are the main clinical manifestations, and the worse prognosis in patients who have a diffuse disease as compared to a limited disease. And most common involvement is the involvement of the kidneys, heart, and the pulmonary vasculature that lead to renal hypertension, cardiac involvement, and pulmonary hypertension leading to heart failure. So these are the basically regarding scleroderma. So patient usually presenting in third and fourth decade, and they may have element of Raynaud's phenomena. Usually they present with Raynaud's phenomena, and if you examine them, you will have skin changes, and you will have the visceral involvement if it is a diffuse disease. And early recognition and treatment of the patient is very, very important, because they can have different manifestation of renal, cardiac, and pulmonary complications. Then you can prevent their morbidity and mortality if you recognize your patient at the early phase and treat them in a scientific manner, because there is no definite treatment. It is a chronic disease that can lead to thickening, fibrosis of the skin and internal organs. And pulmonary, renal, and cardiac, they manifestations are more common to have a terminal event. So this is the even patient who have a terminal phalanx loss with disease. So patient may present with just I have a difficulty in swallowing. Patient will show you hand may have a thickened skin and telangiectasia of the face. And in the advanced phase, patient may have scarring of the mouth, and can lead to typical face of the patient with the scarring. And this is the typical face of the patient with the scarring and furrows around the lips, and peak nose, and difficulty in opening the mouth. So, crest syndrome may be a manifestation of limited scleroderma, but diffuse scleroderma is a bad disease, and can lead to whole cascade of pulmonary, renal, and cardiac manifestations. So treatment is according to symptomatic, with the element with early recognition of organ involvement. If patient is only GI symptom with skin manifestation, you can educate them with PPIs, with the low small meals, and increasing the gastric motility with metoclopramide if they have an absorption of malabsorption treatment with doxycycline. But most of the patient, they have a limited disease in 80% of patient, and 20% have a diffuse disease with the involvement of the internal organs. So this is whole scleroderma with its clinical manifestations and investigation and treatment option. Okay, I thank you very much for your, I don't know, I should say for your listening or your attention, but I hope you will go to your topic and try to go for day to day. This is your learning, because Corona is going to be with us maybe for a few months, 1 or 2 years, depends how careful we are and how we can fight against that. But education, your professional training, that will go on with all these hazards of community-based education. And if you can educate yourself, your family, your near relatives to protect themselves by self-caring, putting masks, hand washing, all these stuff. Okay, so you go and read your scleroderma, and I wish you good luck. Okay, thank you very much. Allah Hafiz. If you have any question, let me know. Do you have my telephone number? You can note WhatsApp me if you have any query. You can note down 0300 413007 3. I repeat 0300 413007 3. Any query regarding your topic, if you want to discuss anything, or if you have any something to repeat, if you couldn't understand, we can discuss on coming lectures or even some other means. Okay, thank you very much. Allah Hafiz.